Hello, my name is Ahmad Khalis Benazir. I will be presenting on the outcomes of extracorporeal cardiopulmonary resuscitation, ECPR, in post-cardiotomy patients undergoing congenital heart surgery in Institut Jantung Negara. My supervisors are Mr. Karo Anwar bin Abdul Aziz and Mr. Sivakumar Sivalingam, and I will be presenting on behalf of Institut Jantung Negara. So the pediatric ECMO program in IJN started back in June 2005, and they are focused mainly on post-operative support. The initial setup and training was based in collaboration with the Royal Children's Hospital of Melbourne, and there were a few collaborations with the respiratory team in Glenfield Hospital, Leicester. So a bit about extracorporeal cardiopulmonary resuscitation. ECPR is defined when ECMO flow is instituted during conventional CPR, meaning that the patient has collapsed. CPR is being performed and delivered with manual or mechanical compressions, or within 20 minutes of return of spontaneous circulation without ongoing compressions. So this is the definition that we use to include the patients within our study. So ECPR has increasing popularity in recent years, mainly because of the reports of improved survival and neurological outcomes. Although there have been no randomized trials to ascertain whether they provide additional survival benefits or additional benefits for neurological outcomes, but data from large centers have stated that they do give some impact on the survival and neurological outcomes. In the AHA Pulse Guideline 2019, they have stated that ECPR may be considered for pediatric patients with cardiac diagnosis who have in-hospital cardiac arrest in settings with existing ECMO protocols, expertise, and equipment. And these are from Pulse Guideline 2019 with a Class 2B recommendation, but evidence level of C. There are no universal standards for ECPR downtime, but reports of local protocols at centers worldwide have stated that these extracorporeal circuit is usually instituted within 45 to 60 minutes of low flow time, or CPR. So the objective of this study is to determine whether the outcomes of ECPR in IJN are good. The primary outcome assessed is mortality, and the secondary outcome assessed is neurological outcome. This is a single center retrospective review with data collected from February 2013 until April 2021. The demographics and ECMO-related data are collected from ECMO registry and case notes. And we also look through outpatient clinic notes to determine whether there are any obvious deficits from the follow-up. We also made phone calls to the primary caretaker to ascertain their functional status. So the age of distribution for our ECPR patients, in total, we had 21 patients requiring ECPR from 2013 until 2021. The bulk of the patients requiring ECPR are actually infants, which constitutes around 47%, and children, 33%, neonates, 13%, and also adults, we had one patient, 4%. These are the diagnosis at surgery. The bulk of patients requiring ECPR undergo major surgery. The majority of the cases are patients with transposition of great arteries requiring arterial switch, and they constitute 38% of the total ECPR cases. 95% of the patients who had ECPR actually underwent a biventricular repair, whereas another 5% underwent a single ventricle repair. So the outcomes are expected to be good. As you can see also, TOF constitutes quite a significant amount of patients requiring ECPR. We had two patients TOF requiring ECPR and 2 patients who underwent truncus repair requiring ECPR. So these are the post-operative findings. The duration on ECMO is 4.85 days mean, plus minus 1.6. The mean ICU stay is 17 days. Hospital stay is around 28 days, plus minus 16. So these patients do undergo a prolonged hospital and a prolonged ICU stay. We achieve successful weaning of ECMO in 66% of our patients. Mortality is 52%. Half of our patients survive, which constitutes around 47%. Functional neurological recovery is 90%. So only 1 patient that survived did not have full neurological recovery after ECMO. But this is kind of expected because these patients who have a hemorrhagic stroke or stroke out during the ECMO or during the resuscitation actually don't make it beyond the weaning of the ECMO. So our survival rates are similar to our elective ECMOs. We have a total of 95 patients from 2013 until 2020 who required elective ECMO, and the survival is roughly around 50% as well. So although you expect elective ECMOs to have a better survival chance, but surprisingly our ECPR cases had similar survival rates compared to elective ECMO. And the survival rates that we have so far in IJN are on par with international standards. Some centers have published their survival rates after ECPR, and they seem to correlate with a number of 40 to 50% survival rate. So in conclusion, ECPR, we think, improves survival in post-cardiotomy patients with satisfactory survival rates and also good neurological outcome. Thank you.